Let's dive right in. All right, first scenario. You have a male patient who is inappropriately flirting with a resident and hugs them during the physical exam. What's your next best step? Well, the attending should inform the patient of the hospital code of conduct and switch them to another physician's care. Here's an action potential mentoring test taking tip. Don't force the resident to confront the patient. This can put the resident in a really uncomfortable position. Also, don't put down the resident by telling them that they should have left the room, because then you basically make the resident feel bad for something that was ethically wrong on the patient's behalf. Number 3, lastly, don't ask the resident if they would like to still care for the patient. This is a common mistake, as this can put them in an uncomfortable position where they feel obligated to care for the patient despite it being awkward. And then, of course, a chaperone is not the right answer either, because it keeps the resident in an awkward and unethical environment. So basically, the attending needs to take care of it, talk to the patient, tell them about the code of conduct, and then switch them to another physician's care. Number 2, if a patient requests to date a physician, what's the next best step? Well, obviously you decline the invitation, and then you discuss with the patient that it is not ethical for a physician to date their patient. Obviously you want to be polite about it and not put the patient down, but you have to be very firm with your stance. And here's an action potential mentoring test taking tip. Don't be tricked by the answer choice that says decline the invitation and refer the patient to another provider. This answer does not show that you have actually explained the ethics of this to the patient, and this type of behavior may continue in the future with you or other providers. So the key for this scenario is you have to discuss with the patient that it's not ethical for a physician to date their patient. So make sure that your answer has that part included. Number 3, a patient with seductive clothing, flirtatious activity, inappropriate requests. They intercept you in the parking lot requesting an after-hours evaluation. Well, what's your next best step? You should say, the office is closed, please reschedule and we can discuss your concerns at your next visit. And here's a test-taking tip for you. Do not say, I can't see you now, but if you feel it is urgent, please go to the ER, because that can lead to ER overuse for non-urgent concerns per the NBME. This patient in this question stem clearly has ulterior motives. That's why I put after hours in quotation marks. I think we all know what that means. So if the patient is clearly trying to flirt, they're asking for after hours evaluation, tell them firmly that the office is closed, have them reschedule, and then you can discuss the ethics of that at your next visit with the patient. The key for this type of scenario is you want to set really strict limits and boundaries with the patient. Number 4, if a physician wants to begin dating a pediatric patient's mother, what's the next best step? Well, the physician should transfer the patient's care to another physician. However, there are no circumstances on the USMLE where this scenario is appropriate. A physician is a position of power, and so if your patient is a pediatric patient, you would technically be having an exertion of your position of power by dating the patient's mother. So that is never acceptable in real life or on the USMLE. Number 5, the American Psychiatric Association states that it is never appropriate to date a prior psych patient, no matter how long ago, if there was written documentation of termination of the physician-patient relationship, no matter what. Dating patients is a more gray area for other specialties aside from peds and psych, but it is always unethical for psychiatrists to date their patients due to the intimate nature of the physician-patient relationship as well as power dynamics. And so, on the USMLE, it's always safest to say no dating, just have a blanket statement, but make sure that you know for pediatrics as well as psych that it's a hard no and it's never appropriate no matter what the scenario sounds like. Remember, there's billions of people out there in the world. You don't need to date your patients. Number 6, for physicians who suspect sexual misconduct by a colleague, should they report their colleague to the state medical board or to the police? The next best step will be the state medical board. This does get asked from time to time. So the patient themselves may file a police report, but it is the physician's role and duty to report the colleague to the state medical board. Here's a test-taking tip for you. All correct answer choices in suspected sexual misconduct questions generally mention notifying the state medical board about the colleague. So state medical board, the SMB, is always the key. On another note, if another physician has routinely poor outcomes, you have an ethical responsibility to report that physician to the state medical board as well, to report their adverse patient outcomes to help facilitate an investigation of possible misconduct or substandard care. And so this would be if you've referred a dozen patients to another provider and each time they have a poor outcome, things that clearly could be preventable, they'll make it very obvious for you on the question stem if this is the case, What's your next best step? Well, report them to the state medical board so that they can get investigated to see if they're upholding the standards of care that's expected for physicians. Number 7, are you ethically allowed to attend a patient's wedding or other major life events? The answer is yes. The NBME does permit this type of activity even if there's an established physician-patient relationship. So you don't have to be so distant that you can't attend really important days for your patients. If it's somebody that you've been seeing for years and now you've developed a friendship with them, if they get married or if they graduate from, let's say, college or med school or something like that, sure, you can go visit and attend their major life events. The NBME does not disallow this type of activity. Number 8, if a patient is aggressive with the physician for being late to their appointment, despite being told by the secretary that the physician was running behind due to other emergencies, what's your next best step? Well, the trick answer that everybody falls for is basically reiterating that you're late, you had emergencies, you're so sorry, but that is wrong. Avoid reiterating why you were late. Simply apologize and validate their concerns with an emphasis on collaboratively helping the patient now. And the key here is you don't want to just repeat what the secretary has already told them. They know that. Repeating known information is unlikely to mitigate their anger and can lead to the patient becoming defensive. So don't reiterate that the patient can reschedule their appointment or that you were dealing with an emergency if they've already been told that. That's the answer choice that I always fall for, but now you know. Number 9, for angry patient questions, never, ever, ever pick the answer choice that sounds a little bit defensive, such as, I can see that you're upset right now, but I'm only trying to help you. Those kind of answer choices, no matter how well the USMLE constructs the verbiage and the sounding of the words itself in the sentence, that's wrong. So the most common trick in these questions, you want to acknowledge the patient's frustration, which is correct, but then you showcase being a little bit defensive, which is wrong. So don't fall for that. You want to select the answer choice that is more along the lines of, well, it makes sense that you are angry right now. You've been through a lot. That's a lot more disarming than saying, well, it makes sense that you're angry. I'm just trying to help. Obviously, that can be taken the wrong way. So you want to acknowledge, empathize, and preserve the patient-physician relationship as always. Number 10, for angry family member questions, you want to never select the answer that is, let us set up an appointment to discuss this matter. This is the most common trick on these questions. It makes sense to set up an appointment to discuss the issue once the family has cooled off a bit. However, angry family members deserve an immediate discussion. So your next best step is, I can see that you're upset. Let me explain the patient's medical course and proposed treatment plan. Remember, never select a paternalistic answer choice, one that talks down to the patient. Your role as the physician is to be an educator and collaborator. So remember, don't fall for, let's set up an appointment when the family member has cooled off. You want to immediately discuss with them. Number 11, for patients with large families that all ask a ton of questions, the next best step is to ask the family to establish an individual who is the point of contact with the healthcare team. This is really crucial. Anybody that's ever done an ICU shift, you know how it is. You'll have family members coming in at all points and times in the day, and you'll have to reiterate the hospital course to like 5 or 6 different family members. That's not a good use of your time or the medical system. So have a point of contact so that that person can relay to the rest of the family what's going on. Obviously, if there's updates, you would re-engage the point of contact, have them disperse the updates to the family, but that's the best way to do it. Here's an action potential mentoring test-taking tip. The individual established as the point of contact does not have to be the patient's surrogate decision maker. This is a common misconception. The point of contact can be anybody in the family. Whoever is best equipped and understands the medical course the best is often the person that's the point of contact, even if they're not the decision maker for the patient. Number 12, in questions with overbearing patients or patients that try to book calls after clinic hours incessantly, etc., you're almost never wrong by picking an option that sets clear boundaries, such as, I appreciate you wanting to keep me informed. However, let's discuss the situations that would warrant an urgent call or appointment. See, that's very firm and it's clear boundaries without being dismissive, without putting the patient down, without trying to insinuate that they have other ulterior motives. It's very appropriate response. Number 13, here's an action potential mentoring test-taking tip. I have not seen an answer choice such as, are you feeling pressured by your family to do XYZ, ever be correct, because it encourages a closed response. And that means anytime that you're reading an ethics question, If the question that it's proposing that you ask the patient or the family member is something that can be answered in a yes or no sentence, then that's going to be wrong. Anything that is yes or no is almost always going to be considered a closed response, and it's not an appropriate next best step for ethical questions on the USMLE. So keep that in mind. Anytime I see an ethics question, I make a mental note, read through the answer choices first. Can any of these be answered with yes or no? Boom, cross them off. And that's how I go through ethics questions a little bit quicker. Number 14, the termination of patient care must not constitute patient abandonment, i.e. withdrawing care without notice. However, physicians can terminate a relationship once the patient has no immediate medical needs and has had reasonable time to find a different provider. And that's generally considered 30 days. So a tricky scenario with this is pregnancy. Obviously, you have a lot of appointments that you need to go to during pregnancy. And so during the first trimester, it is acceptable in uncomplicated patients to terminate the physician-patient relationship because patients have time to find another provider prior to their next prenatal appointment or their delivery. During the third trimester, however, it is unacceptable to end physician-patient relationships with third trimester patients or those with pregnancy complications because these patients may have immediate medical needs, mandating weekly prenatal visits with inadequate time to find another provider. So, you can't just terminate the relationship in a patient that's in the third trimester because they need to have adequate time to find another provider, which the NBME says is about 30 days, but there's less than 30 days in between each of their appointments. Here's another tricky scenario, finances. So non-discrimination laws do allow patients to be turned away on the basis of finances, but the physician has a duty to provide emergent medical care until the patient can find an alternative provider. Keep that in mind. Then here's a test-taking tip for you. I have seen questions where the patient was verbally abusive to the staff, they were non-adherent with their care, and they exhibited drug-seeking behaviors, and you were still not allowed to terminate the physician-patient relationship without giving the patient adequate notice or providing a referral to another provider who is willing to accept the patient. So just because the patient's being a dick, or they're not following up with what you recommended, or they're clearly looking for opioids or other drug-seeking behavior, you can't just terminate the relationship. So make sure that the patient has adequate notice or that you provide a referral to somebody else who is willing to accept the patient. Long story short, the safe answer on the USMLE is essentially always provide care until another provider is identified or reasonable time has elapsed, which, like we said, is about 30 days for patients in acute need of a physician. All right, now let's move on to the quality improvement questions. These can be tricky, but if you know some of the basics, you'll get these questions right. So you always want to follow the PDSA paradigm, the plan, do, study, act paradigm. Anytime the question references you utilizing a quality improvement project and it asks you what the next best step is, go with the PDSA method. For example, if you have already planned the project and you implemented it, so that's plan and do, the next step is to study, PDSA. This would entail reviewing the outcomes of the actions you've taken already and assessing whether the goal is being met. You want to review quantitative data if that's an option. Don't select options that discuss doing surveys or talking with staff. You want to look at concrete data during the study phase. Action potential mentoring test-taking tip for you. PDSA is basically just giving you a framework to rely upon for feedback upon a QI initiative. This method has never failed me on a QI question, so make sure that you know it. 16. When a question asks about quality improvement initiatives to prevent or improve a metric in the hospital, what's your next best step? Well, select the answer choice that is the most broad-reaching across personnel. For example, if there are two answer choices that you're stuck between, such as hire more personnel or creating a system to classify high-risk patients to be used by all employees, you want to select the more broad answer choice for the QI questions. So, create a system to classify high-risk patients to be used by all employees. This answer is at more of a system level rather than a personnel level. Therefore, it would have a broader impact for the quality improvement initiative. 17. The factor shown to most improve patient handoff, you got to know this fact. It's systematic sign-out checklists and templates. And so having a uniform way to always hand off your patients makes sure that nothing is missed. This is the #1 factor shown across studies to most improve patient handoff. I've seen that tested.